The screen visible?
Yes, sir, visible, sir.
So, mitral stenosis and anesthesia. This includes the natural history of untreated mitral stenosis. There is a progressive lifelong disease, usually slow and stable in early years, progressive acceleration in the later years, 20 to 40-year latency from rheumatic fever to the onset of symptoms. And after symptoms, additional 10 years before disabling symptoms. So it is a very slow progressing problem. And the main cause, those days, our teachers during our undergraduate days used to say, what are the causes of rheumatic fever? Number one, mitral stenosis is number one rheumatic fever, number two rheumatic fever, number three rheumatic fever. That much of commonest cause is rheumatic heart disease. And SLE, carcinoid, active endocarditis, septal myxoma, all these things are much more rarer causes of mitral stenosis. So rheumatic fever is the most important, and that is the reason why examiners are fond of asking all the questions about rheumatic mitral stenosis. And more common in females, and symptoms occur 2 decades after the onset of rheumatic fever. And age of presentation usually 20 to 30s. Nowadays, it happens even at 40s and 50s. Isolated mitral stenosis will be 40% of cases. Other 60% may have other valvular lesions also associated. Now, what is the etiology of rheumatic fever? It is a immunological disorder of inflammation, which occurs because of the group A streptococcal, hemolytic streptococcal pharyngeal infection. And it is a multi-system disease affecting heart, joints, brain, and all of you would have heard about it. Licks the heart, bites the joint, and all those things, and the cutaneous and subcutaneous tissues. And it remains an important preventable cause because of low socioeconomic status. It is a common infection that happens. But all people exposed to this beta hemolytic A streptococcal infection, will they all develop rheumatic heart disease?
No, sir.
No. Why? All of us would have suffered sore throat with beta hemolytic streptococci at some stage of our childhood. But why all of us are not developing mitral stenosis and only a few unfortunate population develop this problem?
It's
Because
just
they have
untreated.
not untreated. Even if you treat sometimes, and they have a mutagenic strain which is responsible for that. There are 3% of people exposed to that, they have a rheumatogenic strain which is affecting them. Other 97%, they all are able to fight it out. So only 3% will be affected because of the mutation in the antibodies which is not able to find out. And the body produces antibodies against the streptococci. The antibodies cross-react with human tissues because of the antigenic similarity between streptococcal components and human connective tissue, molecular mimicry. There is a strain of amino acid sequence that is similar to the group A streptococcal antigen that is produced between the human connective tissue and this. So immunologically mediated inflammation and damage, which is also called autoimmune to human tissues, which primarily affects the heart, joint, and brain connective tissues. Okay? And the clinical manifestations of rheumatic fever, the infection proceeds 2 to 6 weeks. Acute rheumatic fever diagnosed by Jones criteria, which consists of clinical and laboratory findings. And it can be 1 major and 2 minor, or 2 major with evidence of recent group A streptococcal disease. So this is the mnemonic to remember the difference between this major criteria and Jones criteria. So it can be polyarthritis, carditis, chorea, erythroderma, and subcutaneous nodules. And minor criteria include fever, arthralgia, And previous rheumatic fever, laboratory finding, C-reactive protein, elevated erythrocyte sedimentation, elongation of CPR interval. So sometimes they ask you about this also. And evidences of recent streptococcal diseases, supporting evidences are scarlet fever, throat culture, rapid streptococcal antigen test. All these things can prove that there is a rheumatic fever. And this is the subcutaneous nodules that you can see in rheumatic fever. This is called the erythematous patches with central clearing. And the treatment for rheumatic fever as it is bed rest, supportive therapy, eradication of organism by antistreptococcal. Benzothine penicillin is considered as the drug to treat the streptococcal sore throat. And you can give anti-inflammatory drugs like paracetamol and aspirin. And you can give steroids if the carditis is very severe. And prevention, secondary prevention is against continuing benzoyl penicillin IM every 4 weeks for until the adolescent age is completed. So you have to continue that. And if the patient is allergic to penicillin, you can give erythromycin twice a day orally. And the duration of rheumatic fever prophylaxis will be with carditis, it will be lifelong. Without carditis, will be until 21 years, whichever is longer, for 5 years or until 21 years. And these are all the features of your normal mitral valve. And this is the pathophysiology that happens. Normal valve gets progressively narrowed to less than 2 centimeters. Then elevated left atrioventricular pressure gradient has to push the. You can see in the normal it is only 10 mm pressure in the left atrium. Whereas once the valve gets denuded, it has to rise to 25 mm to push the blood into the left ventricle. And the left ventricular pressure is also dropping. Here it is 120 by 10. Here it is 115 by 16 because of the inadequate filling. So once the orifice becomes less than 1 centimeter square, patient starts developing pulmonary hypertension because the LA pressure is reflected back. And the constant pressure overload on the LA leads to atrial fibrillation, and then it leads to congestive cardiac output because of the decrease in cardiac output. The tachycardia and AF, they reduce the diastolic filling, and so that will cause pulmonary congestion. And cardiac output, moderate stenosis at rest will be subnormally during exertion only. In severe, it will be subnormal even at rest. So moderate patients will exhibit dyspnea only when they exert themselves, whereas severe MS patient will be having orthopnea, difficulty in breathing even at rest. And left ventricular systolic function usually well preserved in patients with mitral stenosis because the muscle is not damaged. In fact, it is underused. But because of the underusage, once you do the repair, suddenly that muscle may suddenly give way if the stenosis has been severe and then been there for a protracted long number of years. And these are the clinical features you all know. Due to decreased cardiac output, patients will complain of easy fatigability and syncope. Due to increased left atrial pressure, they will have pulmonary congestion, dyspnea, orthopnea, hemoptysis, and pulmonary edema. Due to LA enlargement, they may have Hartner syndrome, atrial fibrillation. Due to pulmonary artery hypertension, right ventricular hypertrophy, and right ventricular failure, which will lead on to JVP elevation, liver enlargement, peripheral edema, all these things will happen. The cause of death in patients with severe mitral stenosis is congestive heart failure, embolism, or pulmonary embolism and infection. So these are the features which are normally seen in the Western people very well because of their fair complexion. You can see the smaller flesh, which is called the mitral facies, and they can have raised JVP only when they have the right heart failure. Otherwise, normally they may have a pulse with a low volume. All peripheral pulses are palpable. They will have left parasternal heave due to right ventricular hypertrophy. Atrial fibrillation will have irregular pulse, and you have to diagnose it with a pulse deficit. Hepatomegaly in right heart failure, and tapping apex beat not displaced. Diastolic thrill may be present in some cases in the lateral negative position. In auscultation, all of you know that it's a low pitch rumbling with diastolic murmur, and sometimes that may be confused with other murmurs. So if the examiner is a fond of cardiology, he may ask you about what are the other murmurs that may be associated with patients in mitral stenosis. In severe pulmonary hypertension, there may be a pansystolic murmur along the left sternal border, louder during inspiration and diminished in post expiration, which is called Carvalho's sign. And cardiac output markedly reduced. In silent MS, there will be no murmur detected. So they can ask you, can there be a mitral stenosis with no murmur at all? Yes, if the patient's left ventricle is not at all filling properly and there is drastically reduced cardiac output, they may have a silent MS. And there is a third thing called Graham-Steele murmur of pulmonary regurgitation, which is a high-pitched diastolic decrescendo blowing murmur along the left sternal border. So pansystolic murmur, which is a sign of severe pulmonary hypertension called Carvalho's sign. High-pitched diastolic murmur along the left border indicative of pulmonary regurgitation or pulmonary inefficiency. In the complications which we have already seen, left heart failure, recurrence of fibrillation, flutter, and atrial and features of pulmonary hypertension are parasternal heave and a palpable SQ, auscultation, early systolic murmur, ejection systolic murmur over the pulmonary area, systolic murmur will on that, and Graham-Steele, all these features. ECG, you can have a Mitral, which is a bifid or the first portion will be taller compared to the left. So that is the Mitral, which will be broad notch P waves, atrial fibrillation may be there, and right ventricular enlargement seen in our waves. Diagnosis, the chest X-ray, this will be a common thing kept in the viva, straightening of the left border or otherwise also known as mitralization of the heart. It is a double density enlarged left atrium, and mitral valve calcification may be there, upper lobe veins may be dilated, left bronchus with the horizontal thing may be there. And echocardiography, of course, she mentioned, we have to see for the valve area and then the pressure gradient between the left atrium and left ventricle. And the third important thing is the pulmonary pressure. These three things we have to look into whenever we see that. And sometimes they ask you about the anatomy of the mitral valve. So it has two leaflets, anterior and posterior leaflet. And this is the annulus at which it is attached. And these are the cauda tentina, which is caudate tentina, which is attached to the papillary muscles here. So in acute myocardial infarction, sometimes this papillary muscle rupture may suddenly cause a mitral regurgitation because the cauda tentina will get detached from the papillary muscle, and the patient with myocardial infarction, sometimes they go in for acute MR, and this is called the Wilkins score, which they may ask you. This is because of to assess the pliability and the eligibility of this valve for balloon valvuloplasty or commissurotomy without replacement. So that is decided by that. So the criteria for that, how mobile they are, what is the subvalvular thickening and calcification. These are taken into that, and there are 4 grades. And so if there's a grade 4, it is unsuitable for any balloon valvuloplasty or a commissurotomy. It has to be only replaced. If it is grade 1, you can try, and up to grade 2 also, because the valve should be mobile. Then only you can use it again for some more time. If the valve has become too stiff and fibrous, then it has to be only replaced. And the causes of atrial fibrillation, this is the mnemonic to remember. It includes both cardiac and non-cardiac causes. It is remembered as arrhythmic, A for alcohol and as ASD, RH for rheumatic fever, I for ischemic heart disease, T for thyrotoxicosis, H for hypertension and hemosiderosis, M for mitral valve disease, I for infection, and C for cardiomyopathy and chronic lung infection. So you can say like this, or you can classify them into cardiac and non-cardiac. And patterns of atrial fibrillation, paroxysmal episodes in the treatment spontaneously and are cardioverted within 7 days, may recur with variable frequency. But the beauty is it may terminate spontaneously. Permanent AF continues beyond 7 days, do not self-terminate, including episodes that are cardioverted after 7 days or more. And long-standing persistent AF is AF that is more than 1 year when it is decided to adopt a rhythm control strategy. And permanent AF is decision to stop further attempts to restore or maintain sinus rhythm. If rhythm control strategy be adopted, the arrhythmia should be reclassified as long-standing permanent AF. And symptoms, they can be totally asymptomatic or symptomatic with decreased cardiac output, irregular rapid ventricular rate, loss of atrial contraction, reducing filling ventricle, which may result in palpitation, dyspnea, chest pain, dizziness, and syncope. Or it can produce neurological deficit like TIA or stroke because of a propagation of the thrombus and systemic embolization into organs like spleen, intestine can also be the presenting feature. The consequences are thromboembolism, hospitalization, reduced quality of life, mortality, impaired heart function, and the other problems. So, atrial fibrillation ECG, you should all know how to identify because it will be commonly kept in the examination. And three pillars of management are the first atrial fibrillation with rapid ventricular responsibility. You always check for hemodynamic instability, and if it is present, then you go for synchronized electrical cardioversion. If there is no hemodynamic stability and known LV systolic dysfunction is there, then you go for beta adrenoreceptor antagonist or non-DHP calcium antagonist like dihydropyridine, and then amidrone, optimal control, digoxin is the third choice. This is how you treat it. And symptomatic atrial fibrillation, AF less than 48 hours, more than 48 hours. Less than 48 hours, try pharmacological conversion. Then oral anticoagulation has to be started if AF is persistent more than 48 hours. In sinus rhythm, atrial fibrillation, same day electrical conversion if there is a hemodynamic instability. And once it is beyond 48 hours, first step is to start anticoagulation like heparin and then give the electrical conversion. Whereas if it is less than 48 hours, you can go for electrical cardioversion without even giving because there is the chances of thrombus formation is less before 48 hours. So this is the guideline based on that. And for treatment sake, mitral stenosis is classified into grade 1, grade 2, grade 3. Grade 1 is mild MS by echo, dyspnea less than grade 3. Whereas grade 2 is tight MS, lung congestive symptoms, dyspnea less than grade 3. And grade 3 is tight MS with pulmonary hypertension. And grade 4 is tight MS, pulmonary hypertension with right heart failure. So all these things are concerned. So the treatment varies based on that. If mild grade 1, you can go for diuretics, prophylaxis against rheumatic fever, and in persistent AF, you go for anticoagulation, digoxin, and drugs for rate control. If it is grade 2, still pursue with pharmacological treatment If symptoms are severe, go for valvuloplasty or commissurotomy. If it is grade 3 and 4 stage, you have to go only for a mitral valve replacement surgery. And treatment is for CHF, that is congestive heart failure with physical inactivity, salt restriction, diuretics, and digoxin. Atrial fibrillation treatment, anticoagulation. And for balloon valvuloplasty, the indications are progressive deterioration despite medical treatment, atrial stenosis with complication, asymptomatic patients with single attack, mitral valve varices less than 1 square centimeter. And surgical correction indicated if there is a both mitral stenosis and regurgitation. That case will not be amenable to valvuloplasty. And mitral stenosis with left atrial thrombus or heavy valvular calcification, active rheumatic arthritis, extremely tight stenosis, restenosis, all these things will require complete surgical correction. And the hemodynamic goals that you have to maintain whenever you deal with any cardiac case, this is given in Barash textbook of anesthesia, which I made a mnemonic of PACRRI. P stands for preload, A stands for afterload, C stands for contractility, R stands for rate, other R stands for rhythm, and the last I stands for ischemia. So, anesthetic management goals, maintenance of adequate LV diastolic filling, optimize right heart condition, maintain slow heart rate, avoid tachycardia, maintain sinus rhythm, judicious fluid therapy, especially to prevent pulmonary edema, and maintain adequate SVR, avoid increases in pulmonary vascular resistance, and right heart function support. All these things are the important things that you have to remember. Anesthetic management, which medication to continue, diuretics to evaluate fluid status, and then decide drugs to control AF, continue in the perioperative period like beta blocker or calcium channel blocker. Watch for serum potassium level whenever the patient receives digoxin and diuretics. Warfarin, you have to switch to heparin at least 5 days before. Titrate APTT 1.5 to 2 times normal. Continue the drug post-operatively. And preoperative medication, adequate dose prevents anxiety and tachycardia. Morphine is the ideal drug, 0.1 to 0.2 milligram per kg. And promethazine to prevent vomiting along with whenever you give morphine. And benzodiazepam also reduce the requirement of morphine, and they produce good anxiety control. Anticholinergics are avoided as they increase heart rate. Even glycopyrrolate is not suitable for them. And avoid all anesthetic agents except ketamine have been used. And the etomidate may be the best drug for hemodynamic stability, or tipentone or midazolam. And narcotic, morphine and fentanyl are ideal. Muscle relaxants, you can use histamine, avoid histamine producing, releasing drugs. And panchronium is preferred drug if a patient's heart rate is less than 70 with digoxin. Otherwise, panchronium is also not an ideal drug. It will cause tachycardia. And maintenance, nitrous oxide to be avoided because it can produce increase in the pulmonary pressures. If the pulmonary hypertension is there, nitrous oxide can be avoided. If pulmonary pressures are normal, you can use it. Light anesthesia and surgical stimulation will cause tachycardia and hypertension. So you have to maintain a normal adequate depth of anesthesia. Reversal, when you want to use neostigmine, you combine always with glycopyrrolate and give it slowly in a titrated fashion to achieve the desired effect. Monitoring required are ECG, SPB. Invasive monitoring depends on the complexity of surgery, and you can go for direct arterial pressure monitoring, CEP, and pulmonary artery catheter monitoring in case of patients with severe PAH. And the post-op management, risk of pulmonary edema and right heart failure are there. So you have to continue your cardiovascular monitoring. And there may be a requirement for mechanical ventilation to prevent pain and hypoventilation because of which will result in acidosis and hypercardia, and decrease pulmonary compliance and increase work of breathing, and relief of postoperative pain in neurotoxic opioids and the other blocks will be also be ideal. Inotropic support and vasodilator therapy may be continued if the patient is in severe pulmonary artery hypertension. Now coming to pregnancy and mitral stenosis, these are the changes that happen in pregnancy. You can see it's a decreased LA emptying and the LV filling, which causes a decrease in stroke volume and decrease in cardiac output. So LO pressure increases, pressure gradient develops, and patient goes in for a fixed cardiac output state. And heart control cope up with increased demand. And pregnancy normally causes an increase in heart rate. So all these things are because of the increase in heart rate leading to all these things. And long standing, it will cause a irreversible pulmonary hypertension. Sometimes they give you the volume pressure graphs like this and ask you to identify. So what happens is a normal graph which is shown outside, and the red color one is the relatively fixed stroke volume and cardiac output, the changes that happen. And anticoagulation during pregnancy is a common question they ask you. So subcutaneous or IV heparin can be given up to 12 weeks of antepartum with an APTT aim of 1.5 to 2 times the normal. Whereas warfarin you can start from 12 to 36 weeks and maintain INR at 2.5 to 3, and then again switch over to subcutaneous or IV heparin after 36 weeks. So this is very commonly asked. So first duration of first trimester, 12 weeks, because warfarin can produce the teratogenic effect. So you avoid the warfarin during that time and go for heparin. After 12 weeks, when the organogenesis is complete, up to 36 weeks, you can give warfarin. Then last trimester again to titrate, and because there is anytime patient can deliver, and that time you don't want undue bleeding, which cannot be controlled, you switch over again to heparin. So that is the logic behind that. And this is the Carprex score which he was maintaining about. So what are the risk factors? Prior cardiac event, functional class, reduced systemic ventricular function, left heart obstruction like aortic valve and other valvular involvement. So based on these things, there is a risk score: 0 risk factors, 5% mortality; 1 risk factor, 27; 2 risk factors, 75% mortality. So you have to make sure that you do this to assess the severity. Now, obstetric management we can classify into normal vaginal delivery. So if you plan for vaginal delivery, patient will naturally have some pain and tachycardia. So you have to go for good labor analgesia as a must, which can be in the form of epidural or combined spinal epidural. Okay? And then if it is cesarean section, it is only for obstetric reasons, then epidural spinal or combined epidural spinal or general anesthesia. These are the three choices that you have. So you have to choose among that and then try to manage that. Subarachnoid causes a rapid onset of extensive sympathetic block with intense vasodilatation and sudden hypotension with severe tachycardia. So this is not the ideal technique, but nowadays they say if you know the severity or grade of the disease, you can reduce the volume of local anesthetic and combine it with fentanyl and make up a volume to achieve a level of block up to T12, not to T4 or T5 as required for every cesarean. And that will produce an adequate analgesia for the surgery, because the sensory innervation is only from T12 to L4. So that will be sufficient if you achieve a block up to T12, up to umbilicus. Whereas T4 to T5 block is usually required for the exteriorization of the uterus and the fundal pressure that is given to deliver the baby, and that will be taken care of by adding 25 micrograms of fentanyl to the local anesthetic. So you can give a volume of 1 ml of 0.5% heavy bupivacaine plus 1 ml of 25 microgram fentanyl, which will make a total volume of 2 ml, which can be given subarachnoid. And you can tilt the table little head down to get the level up to T12, and that will be more than sufficient without causing an undue fall in blood pressure or causing a tachycardia. Whereas titrated epidural, of course, and combined spinal epidural are much more safer methods to achieve the desired area. You have more time to manage the hypotension. So you can start simultaneously infusion of phenylephrine or give incremental doses of ephedrine to maintain the BP and prevent the tachycardia. Ephedrine should be very carefully used because it can increase the heart rate by itself. It is an acting drug centrally and peripherally. So phenylephrine will be a better drug to maintain the peripheral vascular resistance. So the obstetric management category 1, immediate threat to life. This is how the LSES is classified according to the Western world. We call it emergency and elective, whereas there they call it as category 1 and category 2, category 3, 4, and category 4 will be almost elective. So the goals for the management are slow heart rate, sinus rhythm, avoid iotocaval compression, adequate preload in the form of venous return, maintain systemic vascular resistance, avoid pain, hypoxia, hypercarbia, acidosis, which may increase the pulmonary vascular resistance. So these are the basic things that you have to write in your answer. And these are all some of the extra things which is not required for this in theory discussion. So choreography found at 32 weeks that is the time of peak hemodynamic load, and metoprolol, propranolol, and diltiazem are safe to use for blockade the rate control. Diuretics such as furosemide may be used to decrease pulmonary venous congestion, but care should be given to avoid over-diuresis. Mitral valvuloplasty can also be considered in severely symptomatic patients who are refractory to medical management with favorable anatomy. If surgical intervention is required, for example, if you want to do a MVR during pregnancy, that is ideally done around 20 to 22 weeks, and at the same time, the fetus has to be very carefully monitored, because open heart surgery to do a mitral valve replacement in pregnancy carries a higher mortality for the fetus. So that has to be very carefully dealt with. So these are all the prosthetic valves that can be done. So valve replacement requires cardiopulmonary bypass, and cardiac surgery carried out on cardiopulmonary bypass in pregnant women is associated with poor neonatal outcome. So hemodilution, changes in coagulation, and complement activation, release of active substances, particulate air embolism, hypothermia, hypotension. These are all the things which have a deleterious effect on the placental blood flow, and that is the reason why the fetus is at a higher risk. So the lower placental flow and pressure worsened by hypothermia results in impaired placental perfusion and respiratory gas exchange. So the ideal gestational age is established a period between 13th and second trimester is considered the safest gestation for maternal. Physiological, hematological have not peaked, and uterine excitability is least, and iotocaval compression is not that much severe. So fetal organogenesis is also completed. So that is the reason why we choose that. And what strategies during cardiopulmonary bypass you have to follow are uterine tone monitoring, fetal heart rate monitoring if fetus is less than 24 weeks, 15-degree left lateral tilt to keep the whatever possible aortocaval compression can be there if more than 20 weeks. And maternal hematocrit should be maintained more than 25, high maternal oxygen saturation. You cannot do any hypothermic procedures in the pregnant woman for open heart surgery, normothermia, high perfusion flow rates, high perfusion pressure, minimize cardiopulmonary bypass time, and pulsatile perfusion, alpha-stat pH management, tocolytic therapy with magnesium sulfate, beta-2 agonist, because premature labor is very common in these cases. And neonatologists and obstetricians should be on the standby for emergency delivery. Okay, so these are the, and cutaneous valvuloplasty, it is done usually under conscious sedation and may be considered for patients with mild MS. And the anesthesia for that approach is transvenous approach and transarterial approaches are there. And there are single balloon technique, double balloon technique, and Inouye balloon technique. And fasting is needed for at least 8 hours for solid foods and 3 hours for liquids. Patient should be hydrated according to standard protocol for prevention of contrast-induced acute kidney injury. And rapid heart rate with AF might interfere with stable balloon dilatation and should be adequately controlled. No specific pharmacological treatment is needed. Most medications can be routinely continued. Warfarin alone should be withheld. Instead, you have to switch over to heparin and give heparin infusion. And pre-procedural transesophageal echocardia is paramount important to exclude LA or LA appendage thrombi. And antibiotic prophylaxis is required. Anesthesia for balloon valvuloplasty is mild conscious sedation. Only for transseptal puncture, which you do, needs analgesia and more sedation. General anesthesia is needed in uncooperative or unstable patient when PE is used to guide transseptal ducted procedure. And so these are all the things that we have to remember with mitral stenosis. Okay. Any doubts on that, Shobika?
No, sir.
Yeah, Hiranmayi.